Hello, everyone. I'm Mr. Malik. I'm one of the founding director and tutor of ISAP. We have totally 16 modules, and I'm starting with this module, understanding types of clinical papers. The reason being, before we can write up any papers, we need to understand various types of clinical papers, which are already published in literature. So, for example, if you want to build a house, you will ask the architect to design your house. So if you want to write a paper, which will stay for millennium in the literature, so you also need to plan it carefully. That's why to plan it carefully, we need to understand various types of clinical papers out there in literature in the first instance. So based on the study design, the papers are classified broadly into observational studies, experimental or intervention studies. The observational studies are quite common in day-to-day clinical practice, and they are further divided into descriptive and analytical studies. So we come across observational studies quite often in clinical practice, whereas experimental or intervention studies are mainly conducted by either an institute or a company. So descriptive studies are the beginning to write any papers. So you can start off with case reports, and if you got more case reports, you can write up as a case series. And if you got more data or access to the database, you can do cross-sectional studies. And if you're employed in a job where you got access for the database and also the data related to certain cohort of the patients, you can do a longitudinal studies. So descriptive studies are mainly divided into case reports, case series, cross-sectional studies, and longitudinal studies. Whereas analytical studies are classified into mainly ecological studies, cross-sectional two-group studies, case control studies, and cohort studies. So here I want to tell the difference between descriptive and analytical studies. Descriptive studies are mainly you are describing a condition of the patient or describing a condition of a rare condition or rare presentation, or you are describing a set of patients in a cross-sectional study or a set of patients over a period of time. All these are describing only. You are not actually analyzing any data. So the cause and effect is not proven in descriptive studies. Whereas in analytical studies, you're trying to see if there's any relationship, any association, any causation, what is the direction of the effect? What is the magnitude of the effect? So that's why medical statistics are involved in analytical studies. Whereas in experimental or intervention studies, usually conducted by a bigger institute or a company, funded by a company or an institute, where you start off like a new clinical trial. And if a clinical trial is successful, then you proceed with random allocation and concealment to see the cause and effect, to assess the magnitude of the effect. And if randomized controlled trials are successful, then you do with a placebo versus treatment. And then after that, you're going to roll into the public domain, into health practice as a pragmatic or explanatory trials. And after rolling out into public domain, you may start doing analysis of the data. If you have any missing data, you still do analysis as if they're still there in the study, which is called intention to treat analysis. So descriptive studies are further classified into case reports. So I'd like to go in detail about case reports. A case report is an unusual condition or a excessive sign or any clinical symptom or a sign which is out of ordinary clinical area. So which justifies reporting and writing up. Therefore, a case report is an unusual condition or an excessive condition or any treatment or anything out of ordinary clinical area which needs to be reporting is case report. So having said that, any missed complication should not be reported as a case report. Any missed complication which is recognized at later date is not a case report. You have to understand that. For example, if there's an anastomotic leak which is recognized later date, you can't write up that I recognized very late and it can become a case report. That is wrong. So to be a case report, it should be out of ordinary clinical arena. When you pull up case reports together, next thing is case series among the descriptive studies. So when you pull up all the case series, case reports together, it becomes case series, which display similar condition or a rare disorder, an apparent excessive clinical sign. So all the cases in case series should have a common feature of and should share common feature to report it as a case series. So case series is a combination of rare case reports. So the next descriptive studies are cross-sectional studies, where a similar subjects displaying similar condition or a group of subjects of similar age or similar disease pattern. For example, 18 years old, 60 years old. So if you study for presence or absence of a disease, like example, inflammatory bowel disease in 18 years old subjects, then it becomes a cross-sectional study in 18 years old. If you look for incidence and prevalence of inflammatory bowel disease in a 60 years old, then it becomes cross-sectional study looking at 60 years old subjects. The main reason for cross-sectional studies is to understand the incidence and prevalence of the disease. So to understand the incidence and the prevalence of the disease, usually cross-sectional studies are done across various databases. The best examples I can give is breast cancer. So women aged about 35 years, it was studied to see prevalence of breast cancer, and then now we know that 8 to 9% prevalence of breast cancer above 35 years old. Similarly, colon cancer in UK is about 9 to 10%. This study came when they did cross-sectional study among the subjects aged more than 55 years old. So it's important that cross-sectional studies will throw an insight on the incidence and prevalence of the disease in the epidemiology. Whereas longitudinal studies are further extension of the cross-sectional studies related to a group of subjects over a period of time. So in cross-sectional study, you're observing at certain point in time, whereas in longitudinal studies, you follow them over a period of time, and there's more research done in the compared to cross-sectional study, and the subjects are followed one or more time to assess the prognosis or the outcome of the disease. So longitudinal studies are mainly aimed at surveillance of the disease or to find out the confounding factors, modifying factors of the disease progression. So in cross-sectional studies, one can find out prevalence and incidence of the disease, but in longitudinal studies, one can also see how the disease progresses, what is the prognosis of the disease, what is this, and also rules out any confounding factors during the disease progression are the confounding factors in disease modification. And also, surveillance can be done in longitudinal studies. So that's why longitudinal studies should be done in a setting where you got access for a database, or you got a job role where you can study a group of subjects over a period of time. They are very expensive to do. Observational studies are further divided into descriptive and analytical studies. So I'm going to describe in detail various types of analytical studies. The first of all, the analytical studies involves medical statistics, whereas descriptive studies does not involve medical statistics. Analytical studies are further classified into ecological studies, cross-sectional two-group studies, case control studies, cohort studies. So now I'm going to talk about ecological studies, which are the standpoint, beginning point of the analytical studies. So here, population data is studied for a disease frequency, exposure to the risk factors, any mortality data, any cause and effect relationship between any risk factors versus disease progression or disease condition. Ecological studies gives us an insight about any relationship between cause and effect. So these are the beginning standpoints where one can learn there is a relationship or there is no relationship. The best example I can give is the global warming and rise of carbon dioxide. By measuring this carbon dioxide serially, we know now that rise in carbon dioxide levels in atmosphere are causing global warming. This is achieved by doing ecological studies. There are many examples I can give. Another example I can give is the extinction of the species and the risk factors for extinction of the species. Here, there is a linear relationship between a risk factor versus a disease condition or a prevalent of, or a condition which is, or a pattern of a disease which is in progression or in study. So it displays a linear regression model. Ecological studies are the beginning of any analytical studies. Next comes is a cross-sectional two-group studies, which shed light on cause and effect. Now we know that there is a cause and there is an effect. You can draw some conclusions towards cause and effect, and you can divide into groups, two groups with and without of disease, and study the risk factors. Here, the limitation of this cross-sectional two-group studies is you can't predict the direction of the effect. So the mainly cross-sectional two-group studies are aimed at studying risk factors and outcomes of a condition or the disease. But unfortunately, the cross-sectional two-group studies cannot predict the direction of the effect. So the best example I can give is, now we know that global warming is caused by a rise in carbon dioxide levels. So can we predict if the carbon dioxide levels goes down by a certain amount? Can we predict that the temperatures will go down by certain levels? It is not possible. So that's why they are unidirectional. So the cause and effect could be unidirectional or bidirectional or multidirectional. So one cannot establish direction of the effect. And the next analytical type of studies are case control studies, where you can predict the direction. But unfortunately, it involves cases and controls. Cases are defined as a group of people with same condition or disease, and controls are the group of subjects disease-free or absence of the disease. Here you can link a cause and effect, and you can predict the direction over a period of time. The best example is hypertension and stroke, heavy smoking and lung cancer. And the other negative examples I can give is whether ulcerative colitis is a manifestation of measles vaccination in childhood. So this can be achieved by case control studies, where cases are the subjects which have got ulcerative colitis. Controls are the group of individuals, grown-up individuals who have received measles vaccination in childhood but didn't suffer with ulcerative colitis. So you can see the differences between cases and controls and study the risk factors, and you can establish the direction of the effect between cause and effect. So finally, cohort studies. If you want to measure the magnitude of the effect, you can do with the cohort studies, which involves a large number of population. A group of subjects are divided into two groups. One group receives certain type of treatment, other does not, to see the effect of treatment. The best example I can give again is measles vaccination, whether it can lead to ulcerative colitis in adulthood. You can divide into two groups who have received measles vaccination. All the groups, both groups should have received measles vaccination. And some subjects have developed ulcerative colitis group 1, and those subjects who have not developed ulcerative colitis are group 2. You can see the differences. You can study the risk factors. You can predict the magnitude of the effect. And another best example I can give is the pregnant woman in postpartum, while they are in labor, if they receive epidural anesthesia, some complains of back pain and some does not, but all of them have received similar intervention, epidural anesthesia. Now one group has got back pain, other does not have back pain, and we can establish the magnitude of the effect, and the cause here is epidural anesthesia. So therefore, the cohort studies can not only predict the direction, not only establish relationship between cause and effect, it will also give the magnitude of the effect, but involves large number of cohort of the subjects. Therefore, there are some differences between case control studies and cohort studies. So case control studies involves a small group of subjects, so they are inexpensive, whereas cohort studies involves larger group of subjects. They're very expensive, and cohort studies are conducted over a period of time, longer duration, where case control studies are studied over a period of short duration. So case control studies, sometimes you may not see any outcome, but in cohort studies, you have to wait for the manifestation of the outcome. And as I said earlier, it involves a small number of subjects in case control studies. In cohort studies, it involves enormous number of subjects. So in case control studies, we already know who has got disease, who doesn't have disease. In cohort studies, we can't know when we include the patients whether they have disease or not. Only at the end of the study or a trial, you know that these patients have got disease and this patient does not have disease. So you do a retrospective analysis of the risk factors and causes. So therefore, the case control studies are more prone for bias, whereas cohort studies are less biased. There is no selection bias in cohort studies, but there is a selection bias, there is inclusion bias in case control studies, because you predefine what are the cases and what are the controls. Whereas cohort studies, you don't have any selection bias. But both case control studies and cohort studies are not blinded. So therefore, they have a confounding factors, other confounding factors. So both are prone for confounding. So that's when the experimental or other types of trials came into existence. So next type of studies are experimental or intervention studies. So these are further divided into trials, random allocation and concealment, placebo and treatment as usual, pragmatic and explanatory trials, intention to treat analysis. Now I'm going to go into details about trials. What is meant by trial? So the concept, the researchers have introduced trial concept derived from in the past, because the experimentation was done only on some group of subjects. So it's a trial on some group of subjects. That's why the word trial come into existence. If you randomize the group of subjects, it becomes randomized trials. If you don't randomize, it becomes non-randomized trials. So here you're comparing the two groups of the subjects, one who has received intervention, one who hasn't received intervention. So this is to check if there is any compelling evidence that is favoring the treatment. And the disadvantage is that the patient's condition can improve naturally. So that is the disadvantage of the trials. So that's why the next stage comes is the random allocation and concealment. So where random allocation and concealment, you are randomizing the subjects which are receiving the treatment versus placebos or a second treatment. So you have to conceal the allocation within a sealed envelope. The disadvantage is sometimes the sealed envelope can be tampered. So to avoid that, you can do a telephone calls or internet use of internet to randomize. This reduces a selection bias. You can do randomization along with blinding. It could be single blinding, double blinding, masking the recruiters, masking the analyzers, masking the trial conducting authority. So which deals with confounding effects. And also there is another procedure called Jellin's procedure, where the randomization is followed by consenting for a particular type of treatment. So the randomization precedes the consenting, which is called Jellin's procedure. So this carries high internal validity and deals with any confounding effect. Unfortunately, the randomization lacks low external validity due to small proportion of patients who agrees for the treatment. Therefore, another type of trials came into existence, which is placebo versus treatment. So you can design various treatments versus placebo. So it's a patient's choice as well at the end of the day. So here we test active ingredient versus passive ingredient, or simply an exercise or a new treatment versus standard treatment. For example, a new technique versus standard technique. For example, while doing a sentinel lymph node biopsy, you can compare the standard technique versus magnetic technique, where in a standard technique, you use radioisotope dye, technetium 99 and blue dye to identify sentinel lymph nodes. But in a magnetic tracer technique, you just use a magnetic probe. So you can compare the sentinel lymph node harvesting rates between the two procedures. This is also so placebo or treatment as usual. So if there is a treatment available, standard treatment available, it is unethical to withhold from a patient who has got disease condition who needs treatment. Therefore, a protocol should be in place to identify those patients who definitely require treatment. That's where the pragmatic or explanatory trials came into existence. So explanatory trials is to advance the scientific understanding, and we design inclusion and exclusion criteria. Based on inclusion exclusion criteria, they will receive treatment. And also random allocation is done in explanatory trials to see if there's any efficacy of treatment, particular treatment. and to see if they benefit from specific treatment. So ideally, explanatory trials will provide some prove if there is any benefits from treatment. But in real life, the pragmatic trials are more robust and they're not lab-based, whereas experimental studies are lab-based. So pragmatic trials are in day-to-day practice in clinics, in hospital setting. So to evaluate the effectiveness of the intervention. So the pragmatic trials mainly focus on the treatment, not for any confounding factors. And it's mainly to check the management protocol, whether it's going in right direction. So here the management protocol is under scrutiny. So here the treatment is under test rather than for any confounding effect or any other things. So it's the day-to-day practice. So pragmatic or explanatory trials are more robust. So finally, we have to deal with dropouts and missing data. That's where the intention to treat analysis came into existence. Here we deal with missing data mainly, and this is mainly intended to do a robust analysis. This simply masks any unresolved bias. That's why, although intention to treat analysis is great achievement to report the trial results, but in real world, the pragmatic trials are very ideal and very effective. So most of the time, the intention to treat analysis is to deal with the missing data. And they're intended to signal robust analysis of a trial.